all. If I could just, yeah, perfect. Christine has started the recording. That's fantastic. If I could just ask Christine and Sue to continue admitting people as we go along, that would be great. So welcome to the webinar today. A little bit of housekeeping before we commence. Just to ask you all to please remain on mute, just to help us reduce the background noise. And there's going to be time for a Q&A at the end if you do wish to speak then. We do absolutely encourage use of the chat box for discussion and questions. So please feel free to pop your questions in the chat box throughout the presentation as the questions come to you, and we will have time to answer at the end. And as you can see, the webinar is being recorded, so you'll be free to share it with your colleagues who weren't able to make it afterwards. A little bit about Teams, just in case Teams is a little bit new to you. So you should be able to bring this bar up by clicking any part of your screen, or sort of moving your mouse. And you can see here from left to right, this is the turning on and off your camera button. This is how to mute and unmute yourself. This function might be useful later for the Q&A. You can, if you'd like to ask a verbal question, you can just raise your hand, and we'll come to you and you can ask your question off of mute. But just do remember that once you have asked your question, to click the hand again to lower your hand. And here is the chat box here. So this little speech bubble to view and use the chat box for questions and discussion. And if you're having any connection issues, there are a couple of tips we could share with you. Try and move to a place where the Wi-Fi signal is a bit stronger. If you can't hear us, hopefully you can, try headphones if you don't have any sound. And if you can turn your camera off if your Wi-Fi is poor, and if none of that works, feel free to leave and rejoin the call using the link that we sent initially. So today's webinar is the PCN Cancer Early Diagnosis Specification, what you need to know and how to get started. So again, a really warm welcome to you all. It's fantastic to have so many of you on the call. And just to introduce who's on the call. It's myself, I'm Caitlin McGovern. I'm from Cancer Research UK, and I'm a facilitator for South and Northwest London. And I'm joined by Dr. Shanaz Meeran. Shanaz, would you like to introduce yourself? Shanaz, I think you're on mute, unfortunately.
Hey, obviously wasn't paying attention. So Shanaz Meeran, some of you look very familiar on the meeting chat. So I've been a local GP in the area since 2007, based at Dr. Johnson and Partners in East Sheen, and a Macmillan GP since 2019. And whilst my remit in that role is mainly supporting GPs and patients from the point of diagnosis through to living with and beyond cancer, I'm here with CRUK discussing early cancer detection because it's undeniably important in the majority of cancers, with an impact on survival rates and quality of life.
Great, thanks very much, Shanaz. And also on the call is two of my colleagues from Cancer Research UK's Facilitator programme, Sue McNulty and Christine Young, who will be helping out with the chat box and other parts of the presentation today. So a quick outline for the session. We're going to introduce by talking a little bit about the NHS long-term plan and early diagnosis. Then we're going to talk about the requirements for the early diagnosis for the network DES. We're going to give you some practical advice for approaching the early diagnosis DES requirements, and we're hopefully going to signpost you to lots of resources that are going to help you out. And we'll finish with a 15-minute Q&A at the end. So I'm going to hand over to Shanaz now, who's going to talk about the NHS long-term plan.
Thanks for that, Caitlin. So a bit of background on the NHS long-term plan. This was published in January 2019 and set out the ambitions and commitment to improve cancer outcomes and other services over the next 10 years. And key to that was the plan to have 75% of cancers diagnosed at an early stage, that is stage 1 or 2. with the aim of having 55,000 more people surviving cancer for more than 5 years. So if we look at how we can go about that, the first of those 4 steps would be greater awareness of symptoms. So key to that is public awareness. You might be aware of the Be Clear on Cancer campaign that came out with posters that advise patients that obviously if they notice blood in their poo, blood in their pee, or have been coughing for more than 3 weeks to see a GP. So that's kind of part of that. And also I think we've got to remember that when we look at international studies, so there was an International Cancer Benchmarking Partnership study, and it was comparing the UK with other countries, both in Europe and including Australia and Canada. And unfortunately, UK performed really quite poorly with respect to long-term survival. And when they asked patients one of the reasons why they didn't visit their doctor if they had symptoms of cancer, 3 out of 10 UK patients in the study said they didn't want to waste their doctor's time. So there's an element of that as well, and I suppose that's even worse during the time of COVID, which we might all be experiencing in terms of getting patients in to see us. The second part of that is the lower threshold for referral to primary care. So you might be aware that we moved in 2015 from a positive predictive value required of 5% to 3% in order to refer someone on the 2-week rule. Currently with COVID, obviously some of those pathways have been amended, and you might be aware that all lower GI referrals, except if they've got a rectal or anal mass, require a FIT to be processed through that pathway, and also most lung cancer referrals require a chest x-ray, but obviously overall the threshold has been lowered. And then there's the accelerated access to diagnostics and treatment. So that includes symptomatic FIT, which has been around for most of Southwest London since 2019, the 28-day faster diagnosis standard, and access to diagnostic centres. Hopefully all of us have access to diagnostic ultrasound, for example. And the fourth part of that is maximising the number of cancers identified through national screening programmes. So this includes also FIT bowel screening, HPV screening with cervical smears, breast screening. Sadly, in South West London, not the lung health checks, which are being rolled out in other parts of the UK, but obviously that would be useful looking into the future. And if we go on to slide 8, what we're looking at is why early diagnosis is a priority. And I think what's really evident here is the contrast in 5-year survival between early and late stage cancer. So we've got 60% survival for stage 1 lung cancer, dropping down to less than 10% for stage 4, and bowel cancer, 90% at stage 1 for 5-year survival, and dropping down to 10% for stage 4. And so if we then look at the next slide, we'll be looking at how we're doing currently. So we're aiming for 75%, and we can see here, based on slides from 2017, that obviously that we're close to 54% nationally. I think when we're looking more locally, it's probably closer to 58%, but we've got a long way to go. What's really evident is the difference between cancer types. So we can see that we're probably achieving that, or well over that, for breast cancer, which is great. And not on this slide, but certainly we are achieving that for melanoma, uterine, and close to that for bladder cancer. But with the deep organ cancers, or those with vaguer, less specific symptoms, we're often well below that. So we can see that for lung cancer, it's closer to 29%, ovarian cancer is 43%, and the other one not featured here is pancreatic cancer, which is the other one that can present quite late. So I'm going to hand over to Caitlin again to then elaborate on the PCN DES.
Thanks very much, Shanaz. So we're thinking about the PCN DES. You know, it's really crucial to recognise that primary care plays a very pivotal role in delivering these ambitions that were set out in the long-term plan. So now to move into the DES and thinking about what the elements are for the early detection of cancer. So for the first element, it is about improving referral practice for suspected cancers. And within this element, there's a focus on being aware and of following NG12, of safety netting, and that patients are receiving the right information about their urgent referral. The second element is to contribute to improving local uptake of the national cancer screening programs by working with local system partners. And the third element is to support the delivery of the above through a community of practice. So this element is really telling you how to do the first two elements. And by engaging in community of practice, we're talking about peer-to-peer learning events, and again, engagement with those local system partners. And the people that we're thinking about here are your local public health departments, your CCG, your STP, the Cancer Alliance, community groups, and any sort of patient participation groups. We will go on to break down each of these elements in more detail. But firstly, just to talk about the QOF, but we do recognise that the QOF for the cancer specification is yet to be completely finalised. However, in the current proposal, PCNs will see that the areas practices are asked to do improvement on the QOF, align with the first two requirements of the PCN specification. So that is improving screening uptake rates and improving referral processes. You'll also see here that with the QOF, practices must also participate in 2 local review meetings, which does align with the final requirement of the specification of the delivery through a community of practice. And really what that sort of means is the PCN will be responsible for supporting their practices to decide and implement the improvement plans and coordinate those shared learnings. I'm going to talk about data now, and this is because a lot of the PCN DES is focused on data, but there's help available to you in the form of Public Health England's fingertips. And for those of you who are unaware of fingertips or unfamiliar, it is a really fantastic resource, and it will give you all the data you require in relation to the DES. So there are many levels of data that are available to you from PHE's fingertips, including practice level data, CCG level data, STP level data, and probably most helpfully, PHE have recently added the ability to look at PCN level data. So they've grouped all those practices according to PCN level, which is going to be really important in helping you tackle the DES. You can then benchmark your data, the indicators that you're looking at, against the England or CCG or PCN averages. So just to talk through the indicators that will be most useful for you in the DES, starting with the 2-week wait referrals at the bottom right. So there's 3 here that would be quite useful to you. You've got your 2-week wait referrals that are indirectly age, sex standardised. You have your conversion rates, which is the percentage of 2-week wait referrals which result in a diagnosis of cancer. And finally, the detection rates, which is the percentage of new cases, new cancer cases in practice diagnosed via a 2-week wait route. And these data sets are available as 1-year data or 5-year combined data. And within these indicators, probably your most useful indicator is your detection rates, because they do look at a slightly larger sample size, and it can really help you to understand what proportion of your cancer cases in practice are being diagnosed down that urgent referral pathway, and then it may help you think a little bit about those cancer cases that are being diagnosed elsewhere. To move on to the screening and demographics part of fingertips, you can see here you can look at your bowel screening coverage, breast screening coverage, and cervical screening coverage, plus the number of emergency presentations. Important here to say that there are no targets as such to achieve for the DES, and the way that fingertips will help you is that you can show you that you have awareness of your local statistics. But unfortunately, there are some data limitations with fingertips. and this is mainly because cancer data sets numbers are quite small, and so it can sometimes change indicators like your detection and conversion rates. So as I mentioned before, those data sets are available to you as 1-year data or 5-year combined. So we would recommend potentially looking at the 5 years combined data to sort of smooth out any of those yearly fluctuations. Another limitation with fingertips is that the data renews at around Christmas time for the April to April of the following year. So currently on fingertips, the most up-to-date data is up to April 2019. But I would stress that this is the most up-to-date data that we have access to. It is what Public Health England uses well, so you're definitely at no disadvantage by looking at the data that's on fingertips, which does go up to April 2019. You can obviously pull data from your local systems, but fingertips is a really great place to start to get that general overview, and it's a good starter to get a grasp on your data as a practice and as a PCN. Here's some screenshots of what Public Health England's fingertips looks like. We're not going to go into detail about how to actually use fingertips in the webinar today, but after the webinar, I will circulate a video that one of our colleagues in Thames Valley created on how to navigate fingertips. And you can see here what the indicators look like on the left and how the benchmarking color-coded graph sort of looks like here. Another really good way to look at data is through auditing. And as you may know, CRUK are in partnership with the National Cancer Diagnosis Audit. Now, Shanaz is going to give a more detailed snapshot of the Richmond uptake of the NCDA. But for those of you who aren't aware, it's been running since April last year. And because of COVID, the deadline for submission has been extended until the 31st of August. So the NCDA is a year's worth of cancer diagnoses, and they were pulled through from the cancer registry, and primary care were asked to fill in the blanks, if you like, so including pathway information, presenting symptoms, the types of investigation, the number of consultations, etc. And the sign up for the NCDA has closed, but for those practices who have signed up and not yet completed their cases, there's still about a week and a bit left to complete as many cases as you can. So I'm going to hand back to Shanaz now, who is going to talk through the first part of the DES about improving your referral practice.
So thanks for that, Caitlin. So now we're going to delve through each requirement of the DES in more detail with some suggested actions you might want to take as a PCN. These are recommendations from CRUK's facilitators based on guidance released by NHS England in March 2020. So the first part is improving referral practice for suspected cancers with a focus on safety netting, ensuring patients receive information on referral. And this is obviously referring to suspected cancers, including recurrent cancers. And so if we separate that into 3 parts, this will be done by supporting practices to review the quality of their referrals for suspected cancer in line with NICE guidance, making use of cancer decision support tools, that's the CDSs, reviewing practice level data, and utilising the new RDC pathways. So I wanted to take this time just to briefly talk about RDACs or RDCs, because I know it's something that GPs are very keen to hear about. So basically, rapid diagnostic centres for cancer are a means of managing patients that may not meet 2-week rule criteria, but also a way of sort of accelerating access to investigation. And the exciting development on the horizon is the establishment of an RDAC at St George's Hospital, with a plan to initially cover Wandsworth and Merton, but hopefully cover Richmond and Kingston patients, provisionally with an outpatient department at Queen Mary's Hospital. Whilst this is still in the recruitment phase and the referral criteria is not finalised, other units which have a rapid diagnostic centre, such as the one at Chelsea and Westminster, cover patients with non-specific symptoms not meeting 2-week rule pathway criteria, or a malignant process evident from tests with no obvious primary site, or possibly patients who are too unwell to wait for a 2-week rural referral, but well enough to attend a hospital appointment. So I think we can all think about patients that haven't really met the criteria. So I had a patient who had worsening anemia, no real bowel symptoms, had a negative fit, and a normal pelvic ultrasound. And it was very difficult to know how to refer this patient when I was wondering about suspecting cancer. Also, for those who are aware of the ADOC, or Rapid Diagnostic Centre at Chelsea and Westminster, they are also in the recruitment phase of an RDAC at West Middlesex Hospital, which will be of interest, I suppose, specifically for Hampton-based GPs. So leaving that aside, the second part of this is building on current practice to ensure a consistent approach to safety netting patients who've been referred urgently with suspected cancer or for investigations to exclude cancer. And we'll go into that in more detail. And the third part is ensuring patients are signposted to or receive information, including why they're being referred, the importance of attending appointments, and where they can access further support. So this slide is really talking about safety netting and why do it. So safety netting is a diagnostic management strategy that ensures patients are monitored throughout the diagnostic process until symptoms and signs are explained and results have been acted upon. And I think key to this is a consistent approach, because we're often doing safety netting either through personal notes in our diaries or using the IT systems such as Daybook or Task Manager, or even spreadsheets, but it would be best to share best practice as per Dr. Brian Nicholson and have a sort of practice-based system. And further, as per Dr. Rowan Pandev, we need to consider if a patient doesn't attend a test or appointment, what the consequence is of that. And also if there's ongoing symptoms despite a normal test, for example, FIT or a chest x-ray, ensuring a plan of follow-up, perhaps utilising the IT system or other admin staff to facilitate that. Because we all realise that any test can have a false negative. Here it's highlighted that up to 25% of chest x-rays will be reported normal in the presence of lung cancer. And in the context of COVID, there definitely is a reluctance of patients to often attend for tests, particularly if located at the hospital. So we need to ensure some level of follow-up when we order a test or think that it's required. So in summary, safety netting as a robust practice level strategy covering tests, results being relayed to patients, and attendance at appointments. So going on to this slide, reviewing your referral practice getting started. So as outlined by Caitlin previously, practice level data via Public Health England fingertips to benchmark against other practices, CCG and England. It's useful to note emergency presentations, but obviously that can be affected by yearly fluctuations. Detection rate, that is the number of cancers detected via the 2-week route versus via emergency or outpatient appointments. But I agree that obviously there's limitations of the data, but even between practices within the PCN there will be differences with respect to demographics, so older patients, level of deprivation, and skewed figures may occur particularly with smaller practices with respect to emergency presentations or even cancer detection rates. So the second part is, if your PCN has taken part in the National Cancer Diagnosis Audit, then you can certainly use your tailored report to identify areas for targeted quality improvement, but more about Richmond's involvement slightly later. And if you haven't taken part in the NCDA, then a PCN audit-wide review of cancer referral quality versus the NG12 criteria can be undertaken. QOF requires a minimum of 20 patients to be audited to meet their specifications. So going on to Richmond's involvement in the NCDA, 13 practices signed up, which is a huge improvement on 0 from 2014-15. And that means that 351 patient cases have been audited. And as Caitlin outlined, the closing date is the 31st of August. So if you're one of the practices, then actually just try and complete as many patient audits as you can, because it will just mean that your personalised report will be more accurate. Due to more than 10 practices submitting data, Richmond CCG will receive a final report in September 2020. Individual practices will also receive a final report in September 2020, downloadable via the portal. And Sheen and Barnes, as a PCN, will receive a PCN report. I just wanted to share that obviously when I was looking at the data that I submitted, what was apparent was the greatest issue with delays in diagnosis often related to private referrals, which you don't always follow up the same way that we would with 2-week rule referrals. So since then, we've tried to, if we were suspecting cancer and referred a patient down the private route, we'd still safety net them in the same way that we do with 2-week rule referrals. And there was also an incidence of a patient with ovarian cancer ultimately, but a lady in her 50s was predominantly bowel symptoms and was fully worked up for bowel issues and reassured that the tests were normal, and ultimately we needed to think about a CA125 or a pelvic ultrasound. So if we go on to the next slide, and these are example actions for PCNs to improve referral process. So 1, increasing awareness and use of the range of supporting resources available to improve knowledge and confidence using NG12. So Gateway C, if you're not aware of it, is a free-to-use online education service for primary care with modules on NG12, screening, and also living and with and beyond cancer. I'd also highlight the health professionals part of the Macmillan website, which is, we've got details later, which has a step-by-step guide and modules on early diagnosis and also the GP contract support. Clinical decision support tools, including See the Signs, which we'll talk about a bit later, Q Cancer Risk, Macmillan Cancer Decision Support Tools, and informatics for NG12, which are available online and as charts. So we've got See the Signs in Richmond, and we've had a really good sign up and installation by practices locally. And this has been available to us from June 2020. And the good thing is it works as a decision tool on EMIS and Vision platforms. And you can type in patient symptoms or the suspected cancer, and it reminds you which tests to complete and also which cancers might be implicated, because there might be several. And I think that's really useful for us to think about. Secondly, it also works as a safety netting tool via the dashboard, because it records patients who are reviewed or referred by this pathway. And it's an easy way of then checking that they're having follow-up after they've been referred or after they've had a test ordered. I would say that the See the Signs team is really responsive, so if there are any issues, then you can get in contact with them really quite easily. There's contact details on this slide and also details of the daily webinar and the demo video. So in summary, this is finance for the next 12 months at least for Richmond. So I think it's useful if we utilise it as a safety netting and diagnostic tool and see if it's worthwhile taking forward. And then we're looking at number 2, current safety netting process and agreeing on a standardised approach within practices. So we can look certainly at or review the CRUK safety netting best practice checklist, which is really quite comprehensive, and review available clinical systems safety netting tools. So there are a number which are linked to the IT systems, such as within EMIS, and even within Vision using Daybook. Practices may be using spreadsheets, but again, I'd like to highlight using See the Signs. Other people may be aware of the UCL electronic safety netting tool, which is also available via EMIS. And then also coding. Coding is really good way of recording safety netting, and there is a code available now, all from October 2020, for demonstrating safety netting. And if we then go into the third part, which is reviewing the information patients are receiving at referral. So again, agreeing and standardising information given to patients at referral. So we've got, for example, the CRUK patient webpage and leaflet available. There's also, if you refer patients on See the Signs, they have leaflets that you can either email or print out, and there's updated leaflets at healthylondon.org. Also agreeing methods for ensuring patient understanding. Often these are times that there's a lot of information to take on, and the best way of ensuring that the patient has taken away the right information is either thinking about whether we provide them with a letter or a text, or if the patient is agreeable, discussing with a family member. And then a standardised process of recording information patients are receiving. So there are read codes available. I know that the read code is 8DAQ, and there are SNOMED codes available as well. And these are often recorded also when you're handing out leaflets using platforms like See the Signs. So I'll hand over to Caitlin now to go on to the other parts of the DES.
Thank you very much, Shanaz. So I'm now going to talk about the next two elements of the DES. So starting with the second part, contribute to improving local uptake of national cancer screening programs by working with local system partners. Now, just to highlight here that COVID has obviously impacted screening programs, and as an update, cervical screening invitations have resumed and should now be returning to relatively normal levels. The bowel screening program for Southwest London recommenced at the end of July, and the breast screening program is due to slowly restart around now with reduced capacity. So the two sort of elements within the screening uptake requirement in the DES. The first is to work with those local partners to agree the PCN's contribution and to improve uptake and coverage and develop an action plan to implement. And this should build on any existing actions across practices and potentially across the CCG. And you should also be thinking about engaging with one group that does have low participation locally. A quick overview of those three national screening programs with the relevant national targets. So you can see here for bowel screening, the national target is 60%, breast screening 80%, and cervical screening is also at 80%. So getting started on this element of the DES, your first port of call will be PHE's fingertips. So look at your current uptake of screening and benchmark yourselves against the CCG and national averages to understand where improvements may come from with your PCN. And then secondly, think about identifying a group where there are inequalities. So you as a PCN will know your population really well, and you most likely already have an idea of your demographics and where you may want to focus some of your quality improvement. But some ideas here would be to engage with men who do have low uptake of the bowel screening program, patients from BAME backgrounds, patients with disabilities, physical and/or learning, and patients where English isn't their first language. And also just to highlight here that Cancer Research UK has a Reducing Inequalities in Bowel Cancer Screening Guide, which has some more information about how to engage with those groups that do have nationally lower participation. So some example actions for your PCNs to think about to improve your local uptake of the screening programs. Firstly, to agree and implement the process for following up screening non-responders across the PCN. Now, there are various methods that have looked at improving screening uptake, and the CRUK's Good Practice Guide for Bowel and Cervical Screening have a breakdown of those interventions, and they include text messaging, recall letters, offering out-of-hours appointments for cervical screening, and again, these good practice guides have lots of resources and example scripts within them. Secondly, think about support for the increased opportunistic endorsement of screening programs at the practice. So ensuring that all staff, clinical and non-clinical, are confident to provide or signpost to information. So you may wish to think about any further training or support staff may need to do so. And secondly, activating the non-responder alerts on those clinical systems. And then the third thing you may wish to think about for the screening element of the DES is to coordinate the active endorsement and promotion of screening programs. So you may wish to think about hosting patient engagement events, displaying promotional resources, or thinking about nominating a practice cancer champion to coordinate the above. We're now going to move on to the last element of the DES, which is to support the delivery of the above through a community of practice, which supports peer-to-peer learning events and engagement with local system partners. So, reflective learning and partnerships, what is required? You can see here that to support those constituent practices to conduct peer-to-peer learning events is a really important part. Looking at your data and trends across the network, specifically within the diagnosis of cancer where patients presented repeatedly before referral. And also, you may wish to think about engaging with your local system partners and putting some names to faces, including PPGs, as I mentioned before, secondary care, the Relevant Cancer Alliance, which for Richmond is the Royal Marsden Partners, RMP, and any other groups locally that could potentially help you to get in touch with all of those elements of the DES and really kind of come up with a well-rounded plan. So we've spoken a lot about data today. So I'd really highly recommend looking at your data at a PCN level, which, as I've mentioned, is now possible on fingertips. Not just at a practice level. And you may wish to sort of understand the differences between practices, because we know that there can be a lot of variation in populations between practices within the PCN, as Shanaz mentioned before. And practices will certainly have their own unique challenges. And that's a really important part of the DES, is about understanding and sharing that learning as a PCN. Also, to encourage your practices to review their cancer diagnoses on a quarterly basis. And as we've talked about a bit, identifying who local system partners are. So some example actions for your PCN to consider. Firstly, schedule a cancer-specific PCN-wide meetings. So you may wish to have that as a clinical meeting first to review your ongoing audit findings and learning event analyses, LEAs, and to invite other system partners. So an example here, if you have identified that there is a diagnostic challenge, maybe consider inviting someone from the CCG or from secondary care. And then meeting to agree quality improvement projects and to share best practice and resources. So here, meeting with the full PCN, having representation from each practice. You can see here I've just mentioned again that QOF requires a minimum of 2 peer review meetings, as I spoke about at the beginning. So you may wish to schedule a meeting fairly soon with your PCN to start thinking about your priorities, to look at the data we've discussed that you can access from fingertips, and start action planning to address the areas you've identified. You'd then want to continue reviewing those action plans throughout the year, holding any audit reviews, those learning event analyses, peer-to-peer learning events, and then coming back together in spring next year to review what you did, think about how well the project went, did you learn anything, and what would you like to implement across the PCN from your learning. And those local system partners. So an example action of how to meet this element is to have introductions with people like myself and the team that's on the call today. You've also met, obviously, Shanaz, who is your Macmillan GP. You know, we've mentioned RMP, the Cancer Alliance, your CCG cancer leads, and any other communications that sort of come from them. There's lots of events that are coming up soon. I believe there's some webinars that are planned in the autumn to help support with specific elements of the DES. You may wish to arrange and attend speed networking events with support from other system partners, and support and encourage the PPG group's engagement as well. I'm now just going to briefly talk about some further resources. So the first one to highlight is the Cancer Research UK GP Contract Hub, which has lots of information and lots of links to things that I've spoken about today, and that Shanaz has also spoken about as well. And it's broken down into the two elements of the DES, reviewing your referral practice and contributing to improving the uptake of screening programs. Lots of links here and resources to each of the DES requirements. The second to signpost you to is the Macmillan Cancer Support Quality Improvement modules. And this is a brilliant resource for those of you wanting to know a little bit more about how to carry out a really comprehensive quality improvement project. We've talked a little bit about quality improvement today, but certainly not in much detail. So this is a great resource for upskilling yourself in that, in relation to the DES as well, in relation to the early cancer diagnosis DES. The RCGP Cancer Toolkits, this has some great links. We talked a little bit about learning events or significant event analyses. There are some templates here that really help you fill out quite a comprehensive learning event. And there are also some audit templates for those of you who haven't participated in the NCDA and wish to undertake an audit. There are some resources here. So these are the contact details of the facilitator team. Myself, Caitlin, Sue is also on the call, and I've also popped down Rosina's email address, who has been supporting Richmond over the last year or so. We'll share these slides with you so you can have all of the links to all of the resources that I've shared, including these email addresses. So that brings us to the question and answer time slot now. We've got 15 minutes. So please do feel free to raise your hand if you'd like to ask a verbal question. But I'll probably hand over to Sue now, who's been monitoring the chat box.
Hi everyone. Well, I've had quite a quiet 45 minutes actually, but we've got a question from Heather Bryan, who says, having reviewed Richmond and Kingston data, are there obvious borough level improvements in screening you can recommend tackling first? We will see these on a PCN level, but our PCNs are rather geographically and otherwise entangled. So I don't know if you've any thoughts there, Shanaz or Caitlin.
Okay, so I'll give it a go. So hi Heather. I think actually the real easy winner is actually looking at cervical screening, because there's actually actions that our GPA is kind of going forward with to try and improve cervical screening rates in Kingston, and also offering support for additional nurses to do screening in hubs, which you might be aware of. They are also looking at videos that you could then feature on your website, and training from Joe's Cervical Trust. So that could integrate really well into what we're talking about here. When we look at South West London, actually, initially Kingston didn't do so well with cervical screening, but I think we've seen some improvements. But I guess, you know, that there could be improvements both in bowel screening and in cervical screening. But I think that would be a good way of just kind of targeting an area and where there is additional support available anyway.
And just to clarify, on fingertips, you can look at the data in, in different formats. So it is available at PCN, but it is also available at CCG level as well, and even at a practice level. So you can actually go in there, and it's GPs often don't expect to be able to see that individual practice level data, but it is there. Anyone? I can't see any hands up. I can't. Oh, I think we may have another one. We've got a thank you from Heather. So I don't know if there are any more questions. Can't see.
Can I just raise the point that you brought up, that Caitlin brought up about the webinars? I know ECTA's probably on the call as well, and that was just to talk about the cancer programme webinars that they'll be organising from September to March. And I think they're planning September's webinar to be on PCN, the PCN DES and screening for all clinicians who couldn't join either today or who just want a refresher. And that will be featuring the Sutton, thanks for saying hello there, the Sutton cancer lead and Macmillan GP. So that would be useful to link into. And actually some really good topics that come up on those webinars following that on both lower GI and upper GI cancer as well.
We've got another question, which is, are secondary care providers hospital able to deal with increased referral rate? I don't think there's an easy answer to that one. I think the rationale behind the latest NICE guidelines was that referrals would increase, and as we've already mentioned in the webinar about increased access to diagnostics will help deal with some of that. There is the rapid diagnostic centres as well, so hopefully where previously patients would have moved around the system quite a number of times, they will get their eventual diagnosis more quickly. But that's it's a pertinent question, but it's not an easy one to be able to answer.
So I guess one of the things we might have to just, in the context of COVID, I think it's really useful if we could make sure that when we are referring patients in, we are doing the appropriate tests. So if they're going straight to test, then making sure they've got their renal function completed before we refer them in. And if we're referring them on the lung cancer pathway, then probably ensuring they've had a chest x-ray. And certainly for lower GI, just making sure they've had a FIT, because they find it much easier to kind of stratify and work out who really needs a scope and who would need a scan if they know what the FIT level is. And in terms of how can will they be able to deal with the increased referral rate? I suppose what we're trying to highlight is that we really need to do something to improve the long-term survival and pickup of early cancers as well. So we've still got to try and do this even with the constraints of COVID. That's how I look at it anyway. But anything that we can do to help our secondary care colleagues is also useful.
We've got a question from, okay, so we've had some more questions. Are PCNs required to report actions and outcome? Caitlin, would you like to respond to that?
So PCNs, what we would recommend is keeping a good record of any of the interventions that you do take up. But in terms of reporting sort of actions and outcomes, there's no reporting element. It is just keeping a good record of what you do undertake, any actions that you do decide to kind of work on. But no, there won't be any sort of monitoring of outcomes or anything like that.
Thanks, Caitlin. We've had a question about RDCs and how they work, and they've said perhaps you could talk through what happens when patients attend the Chelsea and Westminster RDC.
Yeah, so that's from Ellie. So if you're not aware of it, partly because they hadn't really opened up to Richmond, but were serving, but potentially could see our patients because it is located at Chelsea and Westminster. There was this service which was called ADOC, and it's run by a GP called Abhijit Gill. And the criteria was that if you suspected cancer, but the patient didn't really fit into a 2-week pathway, then you could complete a referral and send them to Chelsea and Westminster, as long as they could attend an appointment. And what they would often do is take a comprehensive history, and ultimately they had access to scanning. So often the patient would have scans done, and then they also had access to the MDTs at Chelsea and Westminster. So that we've seen a few patients from our practice being seen there, sometimes directed by secondary care. So I guess it's an easier way of accessing really rapid diagnostics than you might be able to manage in primary care, and also covering those people who don't fit into an easy 2-week pathway.
Thanks, Shanaz. Just to say, we are coming to the close now, but please do give us some feedback about the session. We'll just deal with a couple more questions with the time that we've got. Hector from the South West London SGP has said that in South West London referral rates are nearing back to normal uptake, and some cancer pathways have lower referral rates since COVID, e.g. lung and urology. Trusts are prioritising patients to manage demand, as Shanaz mentions, but better referral management and conducting the right tests in primary care, e.g. FIT before referral and chest x-ray, will help. We've had another question from, forgive me if I've got the pronunciation wrong, Branko Momik, who asks, are GPs able to directly refer to CT investigations for suspected as NICE advised? Shanaz, do you know the answer for that for Richmond GPs?
So my understanding is at the moment we don't have a direct route for that. There was meant to be a route for when we're suspecting pancreatic cancer, but there's no, as far as I know, there's no easy way that we can do that. What we potentially can do is if you did, if you had those, the symptoms and you referred them on advice and guidance, potentially those could be arranged by secondary care, or obviously looking into the future, we would then be able to kind of arrange that through some kind of rapid diagnostic service.
Okay. Thanks, Shanaz. We're getting some comments about the survey link, which says you don't have permission to view. So we will definitely make sure that you do get on. I hope it is working for some of you. It may be to do with the registration, but yes, so please bear with us because we'd really like your feedback on this. This is actually our first London webinar on the DES, so really pleased with how it's gone today. I hope you found it useful. And I think that's it. Caitlin, was there anything to add?
I think there was just one question from Yvonne. Can you tell us who is on the South West London Cancer CCG team? And I think it would be great if, so Hector's on the call. Obviously Hector is part of that team. And I'm not sure if you'd like to share any more details of who else are the key contacts, Hector. Perfect. She's popped an email address there for you. Fantastic. That's perfect.
I think, yeah, if practices want to email the CCG directly, they can do through the South West London Cancer at southwestlondonnhs.uk email address, and one of us in the team will pick up. So we're made up of commissioners, myself as a project manager, and we work with all the clinical leads, including Shanaz, and then we work closely with CRUK and the local screening hubs and the alliances as well, so RMP. So yeah, if you email us, we can direct you to the right people or to the right data and support.
And I'd like just to highlight, obviously, Atten, who's also on the call. So Atten Gowl is the cancer lead for Richmond and Kingston. So he's another link.
Perfect. I could just see another question from Penny. Will we be able to sign up to the NCDA in future? It's a great question. I think at the moment PHE are sort of still working through whether they or how on what frequency they would like the NCDA to be available. That it was obviously 2014 was the last time the audit was conducted, but we really hope and we really wish to see it again in the future. So yes, absolutely, we really would like to be able to offer that opportunity. So keep an eye out for it in the future. It probably wouldn't be next year, but potentially the year after, or in the near future.
Yeah. And just to say thanks as well to all the practices that did take part in Richmond for the NCDA. I mean, 350 cases is a great set of data to be able to draw on, and for the CCG and London to be able to make decisions, based on. So thanks for all your time and effort in doing that. Okay, it's 1 minute to 2. We're right on time, so I think we're going to close it now. Obviously, we've got our email addresses if you have any further questions, and as I say, please do convey your thanks by taking part in the evaluation survey, so we can collate that and use that to further inform our webinars. And have a good afternoon, everyone. Thank you.
Thanks very much, everyone. Just to follow on from what Sue's just said there, please do look out for an email from us. It will contain the updated link. I think I've neglected to change the permissions for the forms. That's why it's not working. So look out for that. That's where you'll find the feedback form, the video for fingertips, and all of the slides from today. So thanks again, and have a great afternoon.
Bye.